It is my privilege to introduce Dr. Lourdes Martinez. She's currently a health communication specialist in the Office of Communication Science at the U.S. Centers for Disease Control and Prevention, the CDC. In her role, Dr. Martinez leads staff training on plain language principles to facilitate understanding and application of clear health communication for web, social and digital media projects, and print materials. She also assists agency programs to develop and implement strategic communication plans to advance clear communication practices. Dr. Martinez earned a doctorate in health promotion and behavior from the University of Georgia and holds a master's in adult education from Florida International University. Dr. Martinez.
Good afternoon, everyone. Thank you so much for coming to this afternoon's session. I must admit that when I saw the slot that I was given, I was concerned. I thought, oh, it's going to be right after lunch on the day right before people start heading out, and it's the last session before the plenary. But I decided to think about it in a different way. I decided to think about it as an opportunity to listen to the other presentations that were going on throughout the conference, to learn and listen to the questions that people, my colleagues, you, were having in these presentations, what the presenters were recommending for us to do to maintain our best practices. And that really gave me an opportunity to hone some of the conversation that I hope to have this afternoon with you. So I turned that frown upside down, if you remember the old Playworld store. So the other two things I do want to say is I know that it's hard to sit in conferences for so long, and given that we're right after lunch, if you start to feel sleepy or uncomfortable, feel free to stand up in the back or move around. I will not be offended by that at all. And two, as we're going through the conversation today, I'd like for you to ask questions. I don't like to leave questions until the end. But with that said, because I know we're recording today, and just for the benefit of folks like myself who may have a little bit of difficulty hearing, if you could use the microphones, that would be really helpful. I also want to say that my colleague Jennifer Harris was not able to make today's conference, but some of the work that I'll be talking about today is hers, and I want to make sure that she gets the proper accolades for that. So the learning objectives that I hope to accomplish in today's session are here for you. I will talk about our definition at CDC of a health literate organization. We'll also talk about our process in developing our path to become a health literate organization. And this is very much a journey. This is certainly not a place that I can stand up here and say we're there 100% all the time. Because this is something that, as you know, in your own organizations, it does take a lot of work, consistency, and thoughtfulness. And then the final one is we'll go through the 10 attributes of a health literate organization that perhaps some of you, if you attended Dr. Abrams' session yesterday, might be aware of. And others, perhaps if you've read the paper from the Agency for Healthcare Research and Quality, might also be aware of. So I'll go through each one of those attributes and tell you what we're doing in that area, and make some suggestions perhaps for those of you that are in clinical settings of some thoughts that you might consider. So for us, a health literate organization is one where people can find information, they can process what it is that they have found, and that they can understand it so that they can make decisions that matter for themselves and their families. So with CDC, for the most part, this experience is happening on our websites. In fewer situations, we might be in health departments. And in some cases, like right now, if we're in the middle of an outbreak, supporting an outbreak, then we will be on the ground working with folks. So it's really important that we attend to these very specific behavioral elements and recognize where we have opportunities to enhance them or to address gaps. So I want to start off so that for those of you that either may not be familiar with CDC's work or it's been a while since you've visited our site, to tell you a little bit about how we started in the field of health literacy and moving forward. And the first thing that really made a difference, so before 2010, we were working in health literacy. Health literacy did matter to the work that we did, but there was nothing that was formalized in terms of a program or an initiative. But with the passing of the law, the Plain Writing Act of 2010 by President Obama, this was the first time that we now had something of a mandate, of a requirement to do this kind of work. And it was centered around plain language for public communication materials. So we already had a specific audience, and we knew that anything that was going out for the public had to be in plain language. And this affected all of the federal agencies. So certainly some groups in the audience may not be a federal agency, but in our case, even if we were working with contractors who were supporting efforts in local public health departments or nonprofit organizations, they had to create materials that were according to the Plain Language Writing Act. Consequently, after the Plain Writing Act was drafted and passed into law, some of the same folks that drafted that also created the Federal Plain Language Guidelines. And this is a really great website if you haven't visited it, because the document the guidelines itself is almost 200 pages, but it is a fantastic document that you can break down and make it very manageable, either if you're doing quick sessions for folks on a clinical floor, or you might be doing site visits to community clinics, or even if you're in a nonprofit and you happen to have a webinar of some sort or some form of education. The guidelines really provide you chunks that you can focus on in your specific delivery or training. So the ones that are here are the ones that we decided to focus on based on the needs that we thought a lot of our materials fell into. And so this became our foundation for plain language training at CDC. So if we think about a recipe for success, this would be the one that we can say is working for us. One of the most important things that I talk to folks when we're thinking about a strategic plan for health literacy, the very first step is to understand what is it that you've got going on already. Because many times when I talk to folks, they'll tell me, health literacy is something extra that I have to do. I've got all these other things that I've got going on. But then I start talking to them about, okay, so you're developing a campaign. You're developing training for staff or for health professionals. You are drafting media messages, media advisories. Health literacy is in all of that. And you are already thinking about the important things, the plain language elements that go into those things. So you're already doing it. It's just a matter of somehow shifting that perspective for them so that they recognize this isn't an addition to their work, but it's an underlying element of their work. And I found a little bit of success there, but that might be something for you to consider if you are having that struggle or that conversation with people thinking that it would be an added element of their work. The other thing that we run into sometimes is that folks will say, well, my organization, or in our case, we have what we call centers, institutes, or offices, CIOs, each with different agendas, different organizational priorities, and oftentimes health literacy does not bubble up to the top of those priorities. Yet it is important for them, for example, in the case of the Democratic Republic of Congo right now with the Ebola outbreak. It's important for us to communicate to the villagers and the healthcare providers what they need to do to stay safe. So that is a priority that matters to folks. That's when we start to stream in the plain language strategies that are important, the health literacy elements that are important for materials so that people can do what they need to stay safe. The other thing that's really, really important to me is measurement. And it's important for me to know that what we're using for measurement is reliable and is consistent. When we've had this conversation, when I visited some of our centers and institutes, they'll tell me, well, I want to measure these things, but then I wonder, well, what do you have available already to capture that number, that metric? And is this a product that you can use once a year, when you need it? How often are you collecting that data? So it's important to have a thoughtful conversation with the people that you're working with or your immediate team to understand what those data sources are. Because it doesn't so much matter all and everything you can count. What matters is that what you can count is reliable and it is consistent. So bringing it down to a manageable place for you, I think, is a really good first step. And that became, for us, examples like web traffic. After we had updated material, it became number of calls to our call center. If we had updated our scripts, It became better products coming out of our scientists' first drafts when we asked them to do a first pass on a media advisory, for example. So those are some ways that you could consistently assess the products that you're doing and obtain metrics that are manageable. It's also important to know what you've done up until this point. So let's say some of you are thinking about starting this process. Well, look back to whatever it is that you're thinking you're going to measure. Look back and see 6 months to a year of where you were so that you have a better understanding of where you want to go and know how big your jumps can be. So in one case, I was sitting around, we were talking about every week we have a message that goes out to anyone who signs up for it. It's a real short email with resources that we have or that our partners have and we promote. And we had something like 70,000 folks signed up for this. And so I said, okay, 70,000 people, that sounds great, but who's opening them? And how many times are these people opening them? So we decided to count just our unique open rate. And this is a metric that we pull from the particular system that we use. Well, our unique open rate, which means one person who opens it the first time, doesn't count every other time this person opens it, was 5,000. That's a big difference. But what we've found is that that number is stable over time, which means that we can count on that amount of people, 5,000 people opening our materials over time, and we see slight uptake in the material depending on the product that we put out. Whenever we put out studies, that spikes up a little bit. Whenever we put out tools that people can use in a clinic setting or immediately, there's a little bit of a spike. So we know what makes a difference. That data also helped us to understand the days of the week that people were more likely to open our emails. Mondays and Wednesdays at 2 p.m., that's the time. So there's a lot that you can think about that can make a difference when you're considering where you're planning to go and having a better understanding of that because you know where you've come from. And then the last part is obviously the measurement, but in reassessing. So it's important not just to say, okay, this is where we started and this is where we want to go. We got there. But it's important to keep measuring. It's important to also recognize what's going on around you and how that makes a difference in people's use of your materials. So having a way to get feedback from your particular audience is really, really important. The reassessing that I'm talking about here isn't just in numbers, but it's also in anecdotal evidence, things that you hear when you walk on a unit or things that you get feedback from by regular mail or on a blog or whatever format you have for information, use it because it can really be a great way to reassess where you're needing to go if your audience's needs have changed. So before I talk to you about our Health Literacy Action Plan at CDC, are any of you familiar with the National Action Plan for Health Literacy? So a few folks, okay, so I'll briefly just mention it so everybody can come along with us in this process. The Department of Health and Human Services, which is our parent agency, CDC is one of many federal agencies under HHS, they developed an action plan to advance health literacy for the federal government, and specifically within our agencies. And the action plan has a number of goals, 7 goals in particular, and they span different areas. So CDC decided to build our plan on 3 of the goals, and that was going to be what we focused our work on. And each goal has a set of strategies and specific measures associated with those goals. So what you're seeing on the screen now are the 3 goals that we chose to focus our efforts on at CDC. And you'll notice that there's quite a bit of an emphasis on training, so the internal focus to the agency. There's also quite a bit on the development of materials. And we're looking at the 3rd goal on specific audiences, so education of students at many, many different levels, because we do have programs that are very specific to children in early education settings, all the way through pre-professional settings. So we certainly are not doing this alone with 1.5 people in the office, of which I'm one. We needed a council, and I've only been in this program now for about 3 years. Before me, the council was formed, I would say probably 10 years ago, And the council is made up of our various centers, institutes, and offices. And we have about 18 of those specific areas. Of that group, there's about 10 that form our national centers. And those national centers are the ones that are focused on specific disease areas or specific work like emergency preparedness or global health. And these are the ones that have a lot of materials for the public. So they're typically the ones where more of the focus is made when we start to put out recommendations for health literacy or plain language strategies across the agency. The council is helpful in that we meet probably about 3 or 4 times a year, and it's possible that you all have something similar in your areas. When I worked in a hospital setting, we had the patient education committee, and that was similarly organized in that we had a representative from each one of the rehabilitative services and an administrator as well. So we talk about the things that are necessary from these different perspectives and get to know where the different needs are, because each group has obviously different ways of interpreting the need that they have with their patients. The council members are also asked to help us promote initiatives within their centers. So CDC, like perhaps some of your organizations, we're not just in one location, we have various campuses. So people are spread out not only within Atlanta, but also across the world. We have many, many different places across the world that we still support from our perspective. So it's important to have champions, whether at the very high level of the center office of the director or within programs and divisions. So these council members that I'm talking about also then have their own small councils within their centers that they can rely on to get information out and then get information back. So one of the responsibilities of the council is to fill out what we call the health literacy report card. And this report card was created first in a Word document. It was just a very simple document that included our 3 goals and each of the strategies under those goals. And twice per year, we asked the council members and their program representatives to fill out the progress that they were making on these goals and strategies in the 6 months prior to the time that they submitted the report card. And what we use the report card in our office is to supply information back up to the Health and Human Services group who asks us annually for progress on plain language. We're asked how many people we're training, the different levels that those people have. So are they reviewers? Are they content creators? They ask us also to distinguish between federal employees and contractors. It's very important for them to know that. And there's a number of other elements that we use and pull from there. But lately, what we've been using the report card for is to focus on quality improvement. So we have one part of the report card asks them to identify what materials they've created with specific tools that I'll mention in a moment. And then we go in and we'll pick randomly a sample of materials, and then we'll score them with those tools that I'll mention. And then we go back to the programs and say, okay, this is where you are in your scoring. These are the opportunities that you have to improve the material. So it's a way for us to have a pulse almost on the work that's going on across the agency and to be a resource for them as well. So the report card that I mentioned used to look like this. And this is not meant for you to read. This is meant for you to get the same impact that they got, which is, come on, this is extra work. I don't want to do this. So what we talked about, because we started looking and comparing at the answers people were giving, they were not consistent. In some cases, we had a lot of blank fields. So we took this to the council. We had a conversation about what are people doing and where do these strategies actually reflect your organizational priorities. So we had a vote. And the new report card is now much, much shorter. And this is one that is a lot more meaningful because it focuses on the specific work that most of these people are doing, which is in the training particularly. That's where their emphasis is. So the report card that I mentioned started off in a Word document is now in what we call the Health Literacy Reporting System. And this product that you see here is called RedCap. Before this, we had SharePoint. And I recognize that some folks may not have the kind of resources that we do in this case, but it doesn't so much matter a fancy platform. What matters is the automation, if at all, that you can create, so that is a more streamlined process for you to collect information. In this case, RedCap was a lot more flexible and allowed us to immediately send out information once we captured it, so people can get a report that they can download for their own center, and we can then get a report that looks at all the agency activity. And so that flexibility in platforms is what we really appreciated. So I mentioned that we look at materials and score them based on a tool, on a criteria. This is our Clear Communication Index, or the index for short. If you're interested to know more about this, we do have a website that is the Clear Communication Index at CDC, so you can take a look at it. But this is a validated tool that was created with quite a bit of input from not only within CDC and the council, but we also tested it with people who create materials as well as just a general health consumer, and asking them, looking at two materials, one that was created with the index and one that was not, what do you understand better? And most of the time, I'd say probably 80% of the time, people were selecting materials that were created with the index and saying that they were able to identify the main message a lot quicker than materials that were not. So we use the index quite a bit to do this kind of assessment for all of our materials. And the one that you're looking at here is what we call the full score sheet, but we also have one that's the modified score sheet, which is 16 items instead of the 20. And the focus for that one might be shorter materials. So it might be a press release or social media or a podcast script, for example. The other thing that we've done now for a few years with different software, commercially available software, is to provide each one of our centers, institutes, and offices with a monthly assessment of their plain language efforts or plain language materials. So we'll select, based on web metrics, the top 3 web pages, for example, or downloads of their center, and then using the software, we'll scan for these 3 particular elements: passive verbs, hidden verbs, and sentence length. And then it will give them a report of how they're doing in this area. And once they have an opportunity to make the edits necessary or recommended by the software, then they can send it back to us if they want us to do a second scan. And we can then look at the reduction in these elements, which is a really nice marker for how they're doing with their plain language. I will be honest to say that this is a challenge. People don't like getting bad report cards, right? None of us do. But what we tell them is that it's an opportunity to have a discussion to better understand. The same thing with the index. I might, in my office, not know the pressures that folks are experiencing in their offices, but if we get a better understanding of, let us scan materials that you're currently developing before they even go out, then that might be more productive for a lot of people, instead of something that you might have put up a year ago and that's not your effort, your emphasis anymore. So we have asked people for this, and we're finding a lot of traction, particularly and really surprising, from our administrative offices. So even folks who only talk to each other from within CDC, our budget group, our HR group, they're using this product now. And it's helping employees to better understand, oh yeah, it's open season, I need to change my health insurance. So this is the sample email that we'll send with the scans of the plain language assessments. And you'll notice that the different colors represent different scores, and this one does not have a green, but the product that we use provides them an Excel and a Word document output for the scan. And it also, if you have Spanish or French materials, it will do a scan on those, but it'll use, the English version uses the Fleisch-Kincaid reading ease. The Spanish and French assessments use the LIX, the LIX score. Here's just an example of the output file. So you'll notice that the version for Excel just takes the specific sentence out of the material, and it'll let you know where the elements are, the issues are. Whereas on the Word file, it will look more like track changes. So there will be a bubble that will come out on the right margin, and it'll flag where the issue is. Another document, and I've heard a few people talk about their own thesaurus, basically. Ours is called the Everyday Words for Public Health Communication. And this is something that also came out of our council. So the group got together and identified the series of words that they were using in their particular centers that had a plain language variation. And what we asked them to do is submit those, and after they tested them. So we used to have this in a PDF that people could download on our website, and it's possible that the PDF may still be out there. And before I move to what it looks like now, I do want to focus on, you'll notice here, it has the word, it has the definition, how we used it originally in the sentence, and then our recommendation for plain language variation. So now it looks like this. It's no longer a PDF. However, from this web app, you are still able to print the list of words, so that that function has not gone away. We just thought that this would be a lot more flexible for people to use, and it's also digital, easy to access digitally, whereas the PDF was a little bit hard to manage. So what you have here is our recommendation of the flow of creating a new communication material. It's quite likely that each one of you in your organizations has a different process. But the reason that I'm showing you ours is so that you think about the importance of something like this. So what we have here are not just the main points that you would go through as you're developing materials, but you'll notice that the rectangles that border the ovals are specific tools, and when we're recommending people use them in that process. That brings to mind, reminds people of, oh, at this point I can use this product to help me think about the words that I'm using, or to help me follow this particular clearance that I need to make sure I do before I submit it for creative design. So that, I think, is probably the best function of this particular diagram, not so much the flow, because it can vary between centers, but telling them where we recommend that they use our materials is probably the value here. So like Wisconsin, we had our little health literacy summit where we invited all of our centers and their council members, their representatives, because we thought it was important for people to sit down and sometimes see each other face to face, where we've gotten so used to just emailing people. In some cases, we might Skype but not look at each other in the eyes, and that's really important, at least for me it is. So we had the summit where we asked all of the centers to look at their health literacy report card, and to think about the goals in the report card and the goals in their specific center, their specific organization, and how they came together, where they came together. We asked them to identify 2 specific measures from the report card. So of those 3 goals, I mentioned that we had sub-strategies. So we asked them to pick 2 measures, and then they had conducted a SWOT analysis on each one of those measures. We asked them to look at the strengths that they had going already into that measure, the weaknesses that they perceived, the opportunities and the threats. And this was really important because sometimes folks hadn't probably thought beyond the weaknesses and threats. They hadn't thought about where their strengths or where particularly their opportunities were. And that summit gave us an opportunity to not only do that within centers, but others can listen to each other. So we have almost 2 sides of the house at CDC. We have the communicable diseases and we have the non-communicable diseases. And some of those folks having conversations across groups really opened up the imagination of some of others who might not have known that there were certain resources available, or there were certain ways that we could be doing things differently and maybe a little bit more smart as well. And then we asked them to, after they did the SWOT analysis, we asked them to create a work plan for the year, so a 12-month work plan, where they looked at the specific SWOT analysis findings and put that into a plan. And the image that you're seeing now is an example of the SWOT analysis. This is one that I made up, so I'm protecting the innocent on this one. But you'll notice that we asked them to rate the difficulty that they had on each one of the measures. And then, more importantly, the reason for voting. We did not ask them to give this particular sample to us, so we weren't going to look at this, but we wanted them to have these honest conversations within their groups, because if they could identify that the problems were coming specifically from leadership or from process or from lack of funds to get training, then this is probably where it was going to be coming out. But we wanted it to be close to the measure so that they could see it side by side and have an honest discussion about it. And then the work plan, and this is the part we did ask them to submit to us, looks like this. And we asked them to identify the specific measure and the milestone. This was really important, and this was probably the biggest challenge, because getting a lot of, most of the people who came were communicators into the room, and having them say, we're going to measure this at this time, and it's going to be hard data, was not easy to sell to my colleagues, because many of them felt that the work that they were doing was not measurable. So we had quite a bit of emphasis on that part of the conversation, which I hadn't expected, but we planned for it the next year that we did the summit. And more importantly, we also asked them to identify when they expected to complete the specific work and who was responsible. Because many times we think about great ideas, but we don't think about who's going to carry them out and by when. And this was a way of getting that down on paper for them. So after that process occurred and they submitted their milestones, I checked in with them about every 2 to 3 months just to see how they were doing, and we conducted what I called technical assistance sessions. 30-minute calls over lunch where we just basically talked about how are you doing with your work, what have you advanced on, where are the areas that you're struggling with, and submitting some of the successes that other groups had had or resources that had been developed. So it became almost a support network for them so that they could just basically discuss where their concerns are. That seemed to have been the function of that technical assistance session. And I'd say that this is not a bad representation of progress. I think we did pretty good doing this. But we noticed that some people, particularly those centers that were in active response over years. So one center was hit with Ebola and Zika back to back. So they've been in a response for about 5 years. They were really pressed to be able to complete some of the milestones. And we recognized that we might need to take a step back in how we were looking at this process. So speaking of lessons learned, what we looked at was, in some cases, leadership was not, or they didn't have face time with leadership. So leadership might not have been aware that these health literacy plans were occurring or were important to the agency as a whole. Measurement was also a bit of a problem, because some of them maybe optimistically felt that they could measure all these activities that they had in mind, but when they looked at what was available, what were the existing data streams, they perhaps didn't consider the day-to-day challenges that they might have, particularly if the measurement tool was in another division and that they were not in, they didn't have that connection already with a staff member. That's a challenge that they may not have thought about. Staff turnover was quite a problem for quite a few people. And this, I put in parentheses here the different types of staff turnover that we experienced. So when you lose a council member, that's a major connection to the activity that's going on in the center. And in many cases, it's the leadership in health literacy that center had. So some people retired, others moved to different places. So that was one thing that in some cases we're still trying to get a council member placed in a particular center. The implementation team, so those folks right down in the nitty-gritty of the work, we lost some of those as well to details or again, movement within the agency or external. And then we had some leadership changes. And as you know, whenever there's a change in leadership, there might be a change in the priority. And a lot of these folks had their specific goal for health literacy hooked to a leader's specific priority. So upon that change, things slightly shift. So as we considered how we might move forward in the future, we thought we need to go with the basics of public health. We need to go with the basics of what that center, institute, or office does on a day-to-day basis, which will never change because that's the foundation of their work, rather than on, what's the new initiative, what's the new campaign, which could change depending on funding or even administration change. So what we've decided to do now is a much more pared back approach. What we did for our centers, for the council, is we decided that we were going to put out what our New Year's resolution was. And it was fairly simple, but we put it out there for them, and we also provided them with our plan and with the measures that we were going to monitor. And we asked each center to submit a resolution. So a lot of us make resolutions at the beginning of the year. Some of us stick to them better than others. But we figured that we would just keep it open and let them decide what it is that they wanted to put forth. And the bullets that you see here are some examples of the overall resolutions that we received. So very much still a focus on training. And one of the things we heard is that people, our scientists or our policy analysts, those outside of the communication realm, were tired of hearing plain language and health literacy. They didn't want to hear those words anymore. So one center said, okay, fine, we're training on clear communication. People flocked to their training sessions. It was a term that was highly motivating to them, and it has gotten quite a bit of traction in that particular center, in the Environmental Health Center. So more people have been using it, and we've found that from their reports of the council members that it's gaining quite a bit of popularity. And thinking about how you brand your initiatives, your efforts is really, really important. And having to, give it a little bit of a shake-up every couple of years is, I think, really important. Because if you're constantly knocking on the door with the same message, people might just lose interest. And one of the things I mentioned when we started today was consistency is really, really important to keep your initiative alive. The other one is building. So now not only are some centers thinking about their health literacy and their plain language work, but they're also looking at other areas that they could expand their work. So for example, our chronic disease center found a lot of the grants that they were putting out required our grantees to work in the area of cultural competence because a lot of those folks put out grants to tribal communities, also minority groups that they're supporting. So that aspect of cultural competence was a gap that they didn't have, and they've added that element for their training as well. And then the matrix approach. This is something that now we're looking at. How can different groups across the agency who are still doing the same they have the same goals, but they might be coming at it from a different background, a different disciplinary background. How can they work together? And for us, the opportunity came with what we're calling the digital first movement. So what you're going to find, hopefully, over the next year when you come to the CDC websites is a bigger emphasis on materials that are on the website that you can easily see across devices instead of PDFs. Now, we won't eliminate all PDFs because there are still some elements that are necessary to keep in that product type, that file type, but most of our materials will start moving to recognize that the majority of people, more than 50% of the people that come to our websites are coming with a mobile device. And that's significant for us. So talking now to our scientists and saying, we can't put this huge background on this page because we're going to lose people before we tell them what it is that they need to do. So considering the device that people are going to come to, we need to focus and use plain language strategies to make sure that the main message is there, and then give them a link to where they can get more information, more background on the topic. And that has been successful in opening those conversations with groups that before may not have had that thought in mind. Okay, so this is the part that we're going to talk about the 10 attributes and where we are as an agency at CDC. This is very much a journey for us. We are not 100%. We have variations across our different centers, but I think that hopefully you can take from this is that, again, it's a process that we're all going through. There are dips, some valleys in there, but there's a lot of peaks that we can also celebrate. So if you're not familiar with the attributes, the ones that I'm showing are primarily the ones that you will see in that paper that I mentioned from AHRQ, but we also take a little bit of a spin on it from a public health perspective, whereas the original paper was written from a healthcare perspective. So with the first one, I put the attribute on the left-hand column, and then the activities that we have supporting that particular attribute on the right-hand column. And I'll describe some of those that I didn't mention earlier in our conversation. I mentioned the action plan and the report card, but product clearance is something that is always a struggle because some of us will put materials in, they'll look one way, and when they come out of clearance, it looks like a completely different material. The plain language is gone, the formatting is gone, because groups that may not have the training necessary to understand why we have to write it in a certain way for a particular audience may not be aware. So this is an opportunity that we have to speak with them and train leaders on why we do what we do for our specific audiences. And we've noticed that in groups where the leadership prioritizes this type of training, which means that they're actually coming to the training so that they can know what their staff is hearing. Those are the groups that clearance is very, very easy and smooth to go through. Whereas groups where we don't have leadership involvement, that's where we have a little bit of friction. But we're working on it. The Plain Writing and Health Literacy Hero Awards. So one of the action plan goals for us is to recognize the work that our staff is doing. And one way is we have what we call the CDC Honor Awards, which cover many, many different topics. But one of the topics is the Plain Writing Act Award. And these folks get nominated one per center. So you can imagine that's a long list of about 17, 18 centers. And they get recognized agency-wide for the work that they're doing in plain writing. But the other one, the Health Literacy Hero Awards, those are awards that my office votes on a set of criteria, and we just award them. It could be throughout the year. They could be recognized as a health literacy hero, or we use them sometimes and celebrate it during October, which is Health Literacy Month. And we have found, and all this is a cardstock piece of paper with a little person who has a cape on it. Simple, there's no money involved, but we do what we call, so our intranet is called CDC Connects. We put their picture on there and we say what they did. And this has brought a lot of pride for folks who get identified as a health literacy hero. So what I'm suggesting here is that you find what it is that makes people feel good about the work that they're doing and that their work is valued, and you tap into that, because I think that that's what we've done with the Health Literacy Hero Award. For the second attribute, it's important to talk about the strategic programming assistance. So there are centers who are more open and interested in maintaining this process, whereas others are not. So I believe one of the presenters yesterday, Dr. Pash Orlo, talked about this. Focus on the ones that are moving forward. And that's what we're doing with our strategic program assistants. So we'll sit with them, we'll talk about the specific measures that they're doing, we'll look at their benchmarks, and we'll create an evaluation where they can continue to track their progress. We have a quality improvement project that is started with our Gateway to Health Communication website. So we're assessing where the scoring of the Clear Communication Index is for that website, and we'll be looking at making changes over the next couple of years. So these are opportunities that we're taking to educate folks on how to better write for that particular audience of the website, as well as improving our materials at the same time. Number 3, I think, is really important in the performance elements. The council developed, many of you know that you have that annual review with your boss, and they go through all the requirements that you have listed on there, and they say, okay, you're doing pretty good in this, you're doing okay in that, do a little better here. The council drafted performance elements for 3 different levels of health literacy proficiency, beginner, intermediate, and expert. And these are elements that people can put into their performance plan. And what it does is that it gives you an opportunity to devote some of your work to doing health literacy in plain language. So they have to give you time to work on that throughout the year. And that gives you time and space that you might not otherwise have if you don't have that element in your performance plan. So that's one thing that we're pretty proud of. A lot of work in the, as I mentioned, with the Digital First initiative, so making sure that all our material is visible and useful across all devices. Responsive design very much still in tune with that. Concept message testing, this is a really neat project that we've just started. So this is going to be internal to CDC, but we have a product that we're going to, it's an electronic platform that will allow message reviewers to receive a product that a program has created, comment on the clarity of the product, the format of the product, and their feedback will go back to program. And all of this happens electronically before it goes out to the public for viewing. So we think that this is an opportunity to get feedback early on, and it's free to programs, created in-house. So it's something that we expect to launch later in the year. And a lot of the other materials that I've mentioned in today's session are here for the other attributes. But what you can see happening here is that we don't have this extensive, comprehensive, difficult approach to getting to be a health literate organization. Rather, it's one step at a time. It's building on the successes that we've had, and it's recognizing, honestly recognizing where it is that we still need to do quite a bit of work on. And I think when we take that approach, we have a higher likelihood of success. So I'm hopeful that I've been able to share a few nuggets that might be helpful to you all. I encourage you to reach out if you have questions or if you'd like to talk a little bit more. We do provide trainings to organizations on the Clear Communication Index if you so wish. But otherwise, I'd like to encourage you to visit our websites. And if you have any questions, please do approach the microphones.
Tim Bartholow, WA Trust Health Insurance Plan, not-for-profit health insurance plan. We have in our own institution a challenge of trying to make sure that we start such an effort, and I'm sure the room is very impressed with what you've done. We want to make sure that 10 years from now we can see the fingerprints, right, of the work that we've started. How do you think about sustaining and sort of remind us of the length of the journey that you've taken? And do you think in a decade that these fingerprints are likely to be there?
That's a great question. I think that it can happen. We are one small example of what other organizations have done, I think. But what matters is that you have top to bottom support, that you have people in each of the areas that are going to be supporting your work. Because if you're just going uphill by yourself, it's not going to work. So what I ask people to do when they're going into meetings with their leadership is to listen to what are the words or the initiatives that are bubbling up. Where is it that the focus, the interest, the motivation, the money is going? That's where you need to then sell your initiative that's going to solve a problem for them. And that's where we have found some success in programs that we know if they didn't provide clear communication for the audience, there was going to be great media attention. They were more likely to follow some plain language criteria. And certainly for us, as I mentioned, the Plain Writing Act was really the teeth that we needed to move a lot of our efforts forward, because it was a law that we had to comply with, and we get measured on it annually. Thank you.
Thank you very much. This is very helpful. I'm Jennifer Dillahay, and I work for the Arkansas Department of Health. And one thing that we've been trying to do in Arkansas is partner with our literacy partners. And so some years ago, our chronic disease program began a really nice partnership with our literacy councils and so forth, but then they were unable to sustain it because the requirements of the grant changed. And so I just wondered, are there ways, or what is the thinking now in some of the ongoing program grants about health literacy so that it doesn't get squeezed out? Because the change of the emphasis, I think, was more on policy changes. And so health literacy is more than just policy. So can you speak to that a little bit?
Certainly. So we've done quite a bit of relationship building with what we call our policy and evaluation office. And those are the folks that draft the contracts and the grants that go out to everybody, public health departments that apply. And what we've asked for them to include in there, and they have, is the requirement that all materials need to be consistent with plain language and demonstrate health literacy. Now, the key that we're trying to get into is for the programs who are writing these contracts out, is to make sure that they're using the same principles we're asking the grantees or the contractors to use as well. And that's still in progress.
Yeah, just one thought was that to push for policy changes, it's going to be real important to have the community behind it.
Yes.
And if you don't have a health literate approach, or even people with health literacy skills to understand these things, it'll be much harder to push the policies. So I appreciate that. The health literacy part's an important part of that.
Yeah, well, I remember back when I was working in a hospital setting, we created what back then I thought was just a partnership, but now I understand it to be a clinical community linkage. And all that means is that when I was a patient education and employee wellness coordinator, I reached out to our local public health department and I said, we have veterans that we're discharging on a daily basis that are going out with nothing into these communities. And we need to work together on improving the knowledge that they have, the access to food that they have, the transportation opportunities that they have. So we started an education consortium where they would come onto our hospital setting when we were getting ready to discharge folks, and they became part of that community resources process. So I think establishing relationships with groups that might be just common allies, as well as thinking about some of the others, like libraries, for example. At that time, I didn't consider partnering with community libraries as much, but that would have been a great resource, particularly with the growth of digital technologies now. So I think that might be one way to get at where you're feeling it's important that we go. All right, folks. Thank you so much for your time. Enjoy the last conference plenary.